So the floor of pelvic cavity, just like the walls, has been formed by the two muscles, levator ani and coccygeus. You can see over here in this model, there is a dark colored line. Actually, this is representing a thickening of the pelvic fascia, which we will just discuss in a few minutes. But you just have to remember that the fascia over the obturator internus, it gets thickened in this region, in the region of obturator internus. And it looks like an arc. So you call it a tendinous arc. Okay? So it starts from the back of the body of pubis in front, and it moves over the obturator margin, the obturator foramen margin, and reaches up to the ischial spine. Okay? So from this tendinous arc is the fibers of levator ani and coccygeus taking origin. So in front of us is an illustration. So we have to orient ourselves first. So this is the symphysis pubis, the bodies of the right and left pubic bones. And at the back is the sacrum and coccyx. Okay? This is the pelvic inlet. And we are looking at the pelvic cavity from down, right? So you are viewing the floor of the pelvic cavity, okay, from below. So in the midline, you can see certain structures which are the openings of the organs or the terminal parts of the urinary system, the digestive system, and also the genital system. So we will talk about the components of the pelvic diaphragm. And you can see that there are bands of muscles. They are U-shaped bands of muscles. They are making the floor of the pelvic cavity. Okay, so the anterior one, which is originating from the back of the body of pubis, or the posterior surface of the body of pubis, is a muscle. It's a sling which is inserting over, like in the midline, on a body which is it's the fibrous tissue, a fibrous node-like structure which is known as perennial body. So on either side, the right and left bands are inserting into the perennial body behind because this is a section through a female pelvic floor. So you can see this is the opening for vagina, and this is the urethral opening, and this is anal opening. And you know that in males, there is no vaginal opening. So at this moment, we will be talking about like the pelvic cavity or the pelvic floor in relation to the female. Okay? So this is, this sling is known as sphincter vaginalis or pubovaginalis, okay? Because it is like this, the sling is originating from the back of the pubis, and it's meeting its counterpart in the midline at the perennial body. So this is the sphincter vaginalis in females, and in males, it's known as levator prostaticus or puboprostaticus. Then the other flap or other slip is again a U-shaped structure originating from both sides, and this is known as the puborectalis, because you can see that it's originating from the back of the pubic bone, and it's creating a sling behind the anal canal, okay? The anal canal is the downward continuation of the rectum, the lowest part of the digestive system, or the lowest end of the digestive system. So you call it the puborectalis. It acts like a sling. It acts like a sphincter. Okay. Then there is a triangular gap between the puborectalis and a muscle, or another component of the levator ani, which is known as iliococcygeus, because this is the region of the ilium bone. Okay, this was the pubis, and this is the ilium. So the iliococcygeus is the muscle which is originating from the part of the tendinous arc, which is close to the ilium, and inserting over the sides of the coccyx. Okay. Then there is the posterior gaps are filled up by another triangular muscle, which is known as coccygeus. The coccygeus muscle is taking origin from the spine of ischium and inserting over the coccyx, on the sides of the coccyx. Okay, as we can see over here, there is a deficiency, a U-shaped deficiency between the two slings of pubococcygeus, or the sphincter vaginalis, here and here. And this U-shaped deficiency is actually allowing the passage of urethra and the vagina in females from the pelvic cavity down to the perineal region. This gap has been filled up by no muscle, but the ligaments. Those are the thickenings of the pelvic fascia, which we'll be just talking about very soon. So these ligaments, if it is in female, the ligaments are known as pubovesical ligament, because they would be between the pubic bone, and the vesicle is referred to the urinary bladder. So pubovesical ligaments would be filling up this gap in females, and puboprostaticus ligaments would be filling out this gap in males. So here the gap is filled by ligaments, which are the condensations of pelvic fascia, and there is another triangular gap between the puborectalis element of pubococcygeus and iliococcygeus element. Another thing that has been left is, like, you can see that the puborectalis and the iliococcygeus muscles, they are coming towards the midline, and they are joining at the back of the anal canal, or the lower opening of the rectum. This region is known as the anococcygeal raphe, okay, or anococcygeal body, because it's lying between the anal opening and the coccygeus, or the tip of the coccyx. So we have a perennial body between the vagina in females and the anal canal. That is the perennial body. But in males, we don't have the vagina, so there is the body, the perennial body is between the urethra and the anal opening. And the anococcygeal raphe is the structure. Again, it's a fibrous body that is for the insertion of the muscles which are coming from the sides, the puborectalis and iliococcygeus. This anococcygeal raphe is between the anal canal, or the anal opening, and the coccygeus, tip of the coccyx. So as it has been mentioned in old literature, many books, that the pelvic diaphragm, or levator ani, is morphologically one entity, right? So we can say that it has three elements. The element which is originating from the pubic region and going to the coccyx region is the pubococcygeus element. Then that includes both of these parts, the sphincter vaginalis, or the levator prostaticus in males, and the puborectalis. Together, they form the pubococcygeus element of levator ani. The second one is the iliococcygeus, which we just have discussed. And the last one, in books, they have been mentioned that the coccygeus muscle actually is the ischiococcygeal element of levator ani, because it's taking origin from the spine of ischium. So in front of us, there is a makeshift model of our pelvic floor, or pelvic diaphragm, or in other words, the levator ani muscle. So at this end, this is the coccygeal end, or the posterior end of the pelvic cavity, and this is the anterior, or the pubic end of the cavity. So in front of us, this red color balloon is representing the levator ani muscle, or the pelvic floor, or pelvic diaphragm. And these small paper clips are representing the organs, the viscera, the terminal ends of the viscera. And the posterior one, or the green clip, is representing the anal canal. The pink is representing the vagina, and the blue colored clip is representing the neck of the bladder. Okay, so this is how our pelvic floor muscle, the levator ani, especially the pubococcygeus element of the muscle, is creating it has slings around the openings of these organs, because these organs, after passing through the pelvic diaphragm, are entering the region which is below the diaphragm, and it is the perineal region. We'll be talking about it very soon. Okay, so you can see that this is how the organs are well placed, and can you see and appreciate the elasticity? Okay, so I would give an example, like an everyday example, that think about levator ani or the pelvic floor as a trampoline. So when you jump over the trampoline, with your weight, it just, descends, yeah, like this. And then it bounces back. This is what is happening actually in our pelvic cavity. So whenever we are coughing, or we are sneezing hard, or we are blowing a whistle hard, or we are shouting, there is a raised intra-abdominal pressure, which is coming from above. And this floor is holding all the end parts of all these organs, the digestive, the urinary, and the genital. So it just, this muscular floor, fibromuscular floor, holds back the organs, and it keeps them, like it prevents them from displacing. And also, whenever I'm coughing, the levator ani is stretching. Okay, this is how it stretches and slings around or clasps around the orifices, the urethral, the vaginal, and the anal. Okay, and the moment we are coughing or we are increasing our intra-abdominal pressure, the floor goes down like a trampoline and then bounces back. Okay, this is what is happening. This is how our levator ani or pelvic floor is working. So the coccygeal end, the pubic ends. And these are, you can imagine, these are the fibers, and they are U-shaped slings. Like, pelvic diaphragm is playing a pivotal role in both sexes, as we know that the rectum and the bladder both are the pelvic organs, and they are highly expandable organs. Okay, so we need the elasticity of the floor during defecation and also during the process of micturition in both sexes. But when we talk about the female pelvic diaphragm, as we can see in front of us, is the urethral orifice, the vaginal orifice, and the anal orifice. So this is a female pelvic floor. For females, it is playing a very, very important role. Why? Because during parturition, the process of delivery, if there is a difficult delivery, there is a disproportionate, the disproportion between the size of the head of the fetus and the pelvic cavity, or due to any other reason, there is a difficult delivery. Sometimes what happens that these fibers, or this pubococcygeal element of the levator ani, that gets affected, and sometimes in very extreme cases it gets torn, like this. There comes a tear in the pubococcygeal element of the levator ani. So you can see over here that this element is actually playing the major role. It's encircling around the urethral orifice, the vaginal, and the anal orifice, because it's creating these slings around these openings. So people, the women who suffer from a levator ani tear during a difficult vaginal delivery, they usually suffer from urinary incontinence later in their lives, because as I have just mentioned, I have demonstrated in front of you that the levator ani or the pelvic floor is like a trampoline. So whenever there is a pressure from above, like from abdominal cavity, in case of coughing or a heavy sneezing, there is a dipping of the floor, and then it bounces back because of the intact tone of these muscles. But what happens if the muscle is torn at one point? So there would be like less tone or no tone of that region. So whenever a woman coughs heavy or sneezes heavy, there would be some sort of dripping or dribbling of urine as a result of raised abdominal pressure over the levator ani or the pelvic floor. So in front of us, this model is having something extra. This is a makeshift fascia. So the pelvic fascia is at times is also known as the endopelvic fascia. It should be described in like 3 headings. The fascia, which is lying on the wall, like it's covering the wall or lateral walls of the pelvis. The fascia, which is present on the floor, and the fascia, which is encircling the organs or the viscera present in the pelvic cavity. There are 2 principles governing this pelvic fascia, the arrangement of the pelvic fascia. One is that the fascia is very tough and inexpandable on the structures like muscles, and which are like the structures which are not expanding, like they are not soft and they're not expanding. So the fascia on top of those structures is tough. It's like a tough membrane. While on the expansile organs, expandable organs, the fascia is almost, missing. Like it's very, very thin membranous. And the other principle regarding the pelvic fascia is it's not present on the bones. Where there is no muscle, the pelvic fascia is not lining the bone. So the fascia over the wall of the pelvic cavity, it's actually, you can see this thin plastic is representing the pelvic fascia. It changes its name. It's one continuous membrane, but it changes its name according to the region it is covering. So the fascia on top of the obturator internus muscle is known as obturator fascia. The fascia which is covering over the piriformis muscle, actually you can see over here the piriformis is completely obscured by the roots of the sacral plexus. So the fascia is lying on top of the sacral plexus, and it's also on top of the piriformis muscle. So that is known as piriformis fascia. Okay? But when it comes to the floor, the levator ani muscle or the pelvic diaphragm, the pelvic fascia, endopelvic fascia, is very, very thin. I would say that it's like just the epimysium of the muscle that is representing the pelvic fascia. Because we know that we don't need any unexpandable structures, membranes covering the levator ani muscle, because the levator ani muscle is responsible for maintaining the tone of the pelvic floor, and it's monitoring or it's controlling the reproductive or the genital system and the digestive and renal system terminal tubes. So we don't need anything which is inflexible. Okay? So the floor of the pelvic cavity, the fascia is deficient. It's like a thin membrane, or we call it the epimysium of the levator ani muscle. Then the pelvic organs, and we will talk about the pelvic organs in our next session. The organs, there are many organs, and this fascia is just again like a collection of loose areolar tissue on top of the expandable organs, because they are constantly dilating and contracting. So we don't want anything which is tough on top of those organs. That's pretty much logical. There is another thing we have to understand, that from above, from the abdominal cavity, the peritoneum is descending down. And this peritoneum becomes the pelvic peritoneum. The pelvic organs are partially covered by the pelvic peritoneum. So there is a lot of dead space which has been occupied by the loose areolar tissue, a lot of dead space between the pelvic fascia, which is overlying the organs of the pelvic cavity, and the parietal or the pelvic peritoneum. So there is a lot of dead space for expansion, and especially in case of females, there is the expansion is very much required, because at the time of parturition, when the head of the baby or fetus is being engaged in the pelvic inlet, or it enters the pelvic cavity, it needs a lot of expansion. So there is a lot of, dead space available. So there is a benefit of having a dead space, and there is a drawback as well of having such loose areolar tissue present in between the organs and the walls. The benefit is, I just have described, that the expansion, there are freely expandable structures, and they need room, so there is a lot of room available. But the drawback or the disadvantage of having so much dead space in between the pelvic peritoneum and the pelvic fascia on top of the viscera is there is too much space available, and in case of pelvic cellulitis, like the pelvic infection, that infection can travel very fast and very widely because of so much loose areolar tissue available. All right, so we actually will be talking about the nerve supply or the autonomic innervation of the pelvic organs later, when we'll be discussing the organ systems individually. But at this moment, I just want you to appreciate that this plastic, the cellophane, is representing the pelvic fascia. And I want you to appreciate the relationship of the nerves. This is basically the sacral plexus, and on top is the lumbar component. So lumbosacral plexus is visible to you in this model. So you can appreciate the fact that the nerves, the whole bundle, is lying behind the pelvic fascia. Okay? It's not on top of the fascia. It's behind the fascia. And this vessel, which is the sole blood supply to the pelvic structures, as well as the wall, this is the internal iliac artery or the hypogastric artery. This is the arterial system. The whole arterial network is in contact with the inner surface of the pelvic fascia. All right, so it is within the fascia. I would say that the vasculature is within the fascia, and the nerves or structures are outside the fascia. The reason for all this arrangement must be that the nerves, which are not the part of, they are not going to serve the pelvic cavity, they have to get out. So they will be, instead of piercing through the fascia, they will go, because they are lying behind the fascia, so they will get out without piercing. While the vessels, all the branches which would be going out of the pelvic cavity into the lower limb, the thigh or the gluteal region of the lower limb, have to pierce through the fascia. So at this point, I just want you to pay attention to the close relationship of the vessels and nerves with the pelvic fascia. All right, so in front of us, we can see that these are the roots of the sacral plexus, and they're forming, because this is the lumbar component of the lumbosacral plexus, which is also coming from above. So we will be discussing these things in detail, but at this moment, I want you to appreciate the fact that together they are forming the largest nerve of the body, which is the sciatic nerve, and it is passing out of the pelvic cavity through the greater sciatic foramen, and it will be a part of the lower limb. Okay, it has nothing to do with the supply of the pelvic structures. But what I want you to appreciate here is the roots of the sacral plexus are completely obscuring a muscle which is supposed to be lying underneath. It's originating from the anterior surface of the sacrum in the form of 3 slips or 3 digitations. That is the piriformis muscle. Okay, so the piriformis muscle, what's the significance? The anatomical significance of the piriformis muscle is its pelvic surface is in contact, or it is holding the cords or the roots of the sacral plexus. There is another muscle here. You can see this is another triangular muscle, and if you remember what we talked about when we were discussing the pelvic floor, this is the last element of the pelvic diaphragm or floor, that is the coccygeus muscle. It's taking origin from the spine of the ischium, and coming and inserting over the sides or the margins of the coccyx. Okay, so this coccygeus muscle, although it is not present in this model, which I'm showing, but you have to imagine, you have to picture in your mind that just like the sacral plexus, there is a coccygeal plexus. So if I say that the roots which are forming the sacral plexus are the S2, 3, and 4, they are forming a true sacral plexus, and the roots which would be forming the coccygeal plexus would be S4, 5, and the coccygeal nerve, which is not like here in this model, you can't see, but you have to imagine and you have to keep in mind that the coccygeus muscle is in contact, the pelvic surface of the coccygeus muscle is in contact with the coccygeal plexus of nerves. Together, these sacral and coccygeal plexus will be serving the muscles present in the pelvic and in the perineal region. Okay, so in front of us, there is a makeshift model, which is actually showing us many features. Here is our famous piriformis muscle, taking origin in the form of 3 slips from the anterior surface of sacrum, and it is, forming like it's tapering off and has to get out of the pelvic cavity. So I'll show you in a minute. Here, the green colored structures, the light green one is the sacrospinous ligament, which was transforming the greater sciatic notch into the greater sciatic foramen. And the dark colored one, the dark green, which you can, if you look from behind, the dark green ligament is obscuring, it's covering up the light colored. So the sacrotuberous ligament is attaching on the ischial tuberosity, and it's covering up the sacrospinous ligament. It is converting the lesser sciatic notch into lesser sciatic foramen. Okay, here is another structure which we discussed like a few minutes back. We talked about a membrane which is obscuring the largest opening in our body, that is the largest foramen, that is the obturator foramen. So this is the obturator membrane. You can see from outside as well as inside, it's covering up the obturator opening. Okay, and here you can see the obturator canal, and I hope that you're able to appreciate the fact that this is from here, the obturator neurovascular bundle would be passing. So there is like this, the bone is beveled, the bone is smooth. This is the obturator canal, okay? Allowing the passage of obturator neurovascular bundle, it will be getting out through this gap and will be entering the medial compartment of the thigh, or the obturator compartment of the thigh, or adductor compartment, okay? All right, so here I can show you one more thing which we discussed. Another muscle which is making the wall, like there are 2 muscles which are making the wall of the pelvic cavity. That is piriformis, and the other one is the obturator internus. Okay, and we said that these muscles have nothing to do with the pelvic cavity. They are the true muscles of the lower limb. So here you can see that the obturator internus is taking origin from all across the margin, the bony margin of the obturator foramen, and also the inner surface of the obturator membrane, okay? And then it forms a tenon, and that tenon is passing through. Now we'll come to our openings, our doors. So one door we just have discussed was the obturator canal, which we just have seen. The other doors are 2, and they are, if you look from behind or from side, from the gluteal side, we can see that here is the greater sciatic foramen, and it is allowing the passage of the tendon of piriformis muscle. And as I have mentioned, that the piriformis is doing what? It is dividing the big opening, the greater sciatic foramen, into an upper compartment, a superior compartment, and a lower compartment. Okay? So we know that from the superior compartment, there are many vessels. Actually, there is just one neurovascular bundle that would be passing through the superior compartment of the greater sciatic foramen, that would be the superior gluteal nerve and vessels. Okay, so they will be coming out and will be supplying the muscles of the gluteal region. Okay, the lower compartment or the inferior compartment of the greater sciatic foramen, which is between the tendon of piriformis and the sacrospinous ligament, this is a bigger compartment. And this compartment allows the passage of many structures, okay? So many neurovascular structures. First of all, our biggest nerve of the body, which is the sciatic nerve, it would be emerging out because it's originating from the lumbosacral plexus, from inside the pelvic cavity, but it has to leave the pelvic cavity because it's not going to supply any structure in the pelvic cavity. It will be coming out and will be entering the posterior aspect of the thigh or the gluteal region of the thigh, okay, by passing through the inferior compartment of the greater sciatic foramen. Okay, other than that, the inferior gluteal nerve and vessels and other nerves and vessels which will be supplying the structures or the muscles in the lower limb will be getting out. Okay, one more nerve which we have to know, it is very important because it's one of the nerves we will be concerned very soon. It's the nerve of perineum. Okay, that is this nerve, the pudendal nerve. What it is doing, it's doing a very funny thing. This nerve is originating from the sacral plexus inside the pelvic cavity above the pelvic diaphragm. Okay, but it's not the nerve of the pelvic cavity. It will not supply any muscle inside the cavity. It has to come out, so it will come out along with its vessels, the pudendal artery and pudendal nerve. It will come out, or pudendal nerve, artery, and vein, the neurovascular bundle, will come out through the lower segment or the inferior compartment of the greater sciatic foramen. And what it will do, it has to bypass the pelvic floor and it will enter the lesser sciatic foramen. Okay, so the lesser sciatic foramen, through the lesser sciatic foramen, the pudendal nerve will enter and, okay, right? This is how it's working. The pudendal neurovascular bundle will exit the pelvic cavity through the greater sciatic foramen, will enter the perennial region, which is a region below the pelvic diaphragm. So in this way, why there is a special arrangement? Because in this way, the neurovascular bundle doesn't have to pierce through the pelvic diaphragm. It will bypass that resistance and will enter because, you can see that the level of greater sciatic foramen is above the pelvic diaphragm, okay? The level of the lesser sciatic foramen is below the level of, or below the pelvic diaphragm. The region below the pelvic diaphragm, we will just discuss in a few minutes, is the perennial region. So the pudendal neurovascular bundle is the neurovascular bundle of perineum. It will come out through the lesser sciatic foramen and will enter the perineum. The other structure which you can see here in this model that is also coming out of the lesser sciatic foramen is the tendon of Obturator internus. So there is a tendon of piriformis and the tendon of Obturator internus. Both of them are coming out of the pelvic cavity through greater and lesser sciatic foramina, respectively. And where they are going? They are going to insert on the greater trochanter of femur. And both of them are the lateral rotators of hip joint, femur and hip joint. Have nothing to do with the pelvic cavity. All right, so there is in front of us is a nerve which has the name obturator nerve, okay? But it's not the nerve of pelvis, although it is crossing the pelvis like many other structures, many other nerve and vascular structures. So it's the only nerve which is coming from the lumbar plexus. While the rest of the nerves, either they are coming from the lumbosacral plexus, like the sciatic nerve, and the other nerves, the pudendal and the inferior gluteal and superior gluteal nerves, all of them are coming from the sacral plexus. But this nerve, the obturator nerve, right and left, is formed by the lumbar roots. L2, 3, and 4, just like the femoral nerve. Okay, but this nerve we know is the nerve of the medial compartment of thigh, or the adductor compartment of thigh. So what I'm trying to show you that this nerve is passing through the obturator canal, which is a gap within the obturator membrane and the obturator foramen. So it will be traveling, the nerve, obturator nerve is traveling along with its vessels and will be coming out. And here, this region, when we'll talk about the female viscera, this is the region where the ovaries would be lying on either side. Just below the pelvic brim or the pelvic inlet is the site of presence of ovaries, okay? So sometimes the ovarian problems, they usually, like if there is an inflammation in the ovary, there is an ovarian cyst which will be compressing over this nerve, okay? So people, like women, they do suffer from pain, especially in the medial region or the medial side of their thigh, okay? That's a dull aching pain. That is the ovarian pain. All right. Other than that, there is another clinical significance of this nerve, that especially like that can happen in both sexes. Like the rectum, there are certain, like here, you imagine that the rectum is the posteriormost structure, and then here is the bladder in males also. So the bladder has around its neck is the prostate gland. We'll be talking about all these structures, don't worry. But you just have to imagine at this moment that the organs, the pelvic organs, are lying here in the floor. And you know that in cases of removal of any cancerous lymph nodes, like as a result of prostate cancer or the rectal cancer, there would be involvement of the pelvic lymph nodes. Okay, so sometimes during the surgical removal of the cancerous lymph nodes, sometimes this nerve gets damaged or gets injured. Okay, so that can happen in both sexes. It's not just females. It can happen in males. Okay, so that will lead to the painful spasms that would be felt by the person in the medial compartment of thigh. Okay, those painful spasms are the result of the injured obturator nerve. So in front of us is the pelvic floor, and the muscles are there, and there is a U-shaped gap, whatever. So I just want to mention at this point that this big band of muscles, the fibromuscular pelvic floor or pelvic diaphragm, is skeletal. It's made up of skeletal muscle fibers. It's not smooth. So it is getting its innervation, motor innervation, by the ventral rami of S3, 4, and S5. So that means that the branches of the sacral plexus and the coccygeal plexus are supplying these muscles, the pubococcygeus, iliococcygeus, ischiococcygeus, making the floor. And along with that, the sensory innervation is also coming from these same branches, the sensory innervation of the pelvic fascia. Okay, and they will be supplying the pelvic surface of the pelvic diaphragm as well as the perennial surface of the pelvic diaphragm, this surface. Okay, so we just have to remember that the motor innervation of the pelvic diaphragm is coming from the lower sacral nerves. The ventral rami of the lower sacral nerves will be supplying the entire musculature and the fibrous tissue of the pelvic diaphragm. So in front of us, again, the same model is showing us some blood vessels, okay? So here is our abdominal aorta, descending abdominal aorta, and here is the inferior vena cava behind and slightly right to the aorta, okay? So you can see over here that this is the fifth lumbar vertebra, okay? Here. So at the level of fifth lumbar vertebra, or L5, the aorta bifurcates into its two terminal branches. So the right common iliac and the left common iliac. And please keep in mind that the veins are the cheaters. They actually follow the pattern of the arteries. Okay, so the same thing is happening. The inferior vena cava behind and on the right of aorta has been forming by the left common iliac, sorry, the right common iliac vein and the left common iliac vein. Together, they join to form the inferior vena cava. Okay, so that is happening at the level of L5, the bifurcation of abdominal aorta. On this side, you can see that this is the sacroiliac joint. Okay, at the level of sacroiliac joint, the left, or on the right side, the right common iliac and the left common iliac will be bifurcating into the right internal iliac and the left or the right external iliac. This would be happening on both sides. So the external iliac will travel further forward and will pass under the inguinal ligament. Once it reaches the inguinal ligament and comes out over the surface of thigh, it's no more known as the external iliac. It is now known as the femoral artery. And there is the femoral vein. Okay? That is the story about the external iliac artery and vein. Now we are concerned because we are doing the pelvic cavity. So our concern is with this vessel, which is the internal iliac. So always remember that the internal iliac has been given off by the common iliac at the sacroiliac joint. Okay? It is crossing, and it's crossing the pelvic brim, and it is entering the pelvic cavity. And I have told you that the arteries are always inside the pelvic fascia. They are in contact with the inner surface of the pelvic fascia. Okay? So the internal iliac, you can see here, because just in the background is the sacral plexus. So internal iliac is divided into the two divisions, an anterior division and a posterior division. Okay? So anterior division and posterior division, and in some literatures, it has been mentioned that the description of the internal iliac branches should be like the parietal branches, which would be serving the wall structures, and the visceral branches, which would be serving the organs present in the pelvic cavity. So when we will discuss the organs, we will discuss the individual blood supply. So mostly it is the posterior division of the internal iliac which would be giving the branches which will be serving the parieta, the walls of the pelvic cavity. Okay? So, for example, like the branches are not visible in this model, there would be a lumbosacral branch, and there would be a median sacral branch, and on and on. So you just have to keep in mind that the internal iliac is the blood supply to the pelvic cavity. Okay? Cavity including the organs. And the internal iliac vein is the sole venous drainage of the pelvic cavity, including the pelvic viscera. These internal iliac artery and vein are also known as inferior hypogastric artery and veins. Again, in front of us is our makeshift model showing the sacrotuberous ligaments. Actually, I'm trying to show you the boundaries of the pelvic outlet, right, which is roughly diamond shaped. And this is also the boundaries of a region which is known as perineum. It's around the anal region, so perineum, so perineum, okay? So we will be talking about the perineum. So in front of us is another model, and let me complete the shape. So my hand is the other sacrotuberous ligament. So you can see that this is the pelvic outlet, which is roughly diamond shaped. And this is also the shape of a region which is known as perineum. Okay, perineum is the region which is lying below the level of pelvic diaphragm. Okay, this is the levator ani or the pelvic floor or pelvic diaphragm. The region below the level of pelvic diaphragm is known as perineum. Okay, and it's of the shape of a diamond, just like the shape of the pelvic outlet. So my probe is the second sacrotuberous ligament, and this is the shape of the perineum. Okay? Perineum is the region which holds mainly the external genitalia and the lower end of the anal canal, as you can see over here. This is the anal orifice or anus. This is the, this is the anal orifice, because look at the coccyx, this is the posterior region, anal orifice, and there are bundles of skeletal muscle fibers which are acting like the external anal sphincter, and then there is an opening for the vagina and an opening for urethra. Okay, so urogenital and the anal openings are present in the perineal region. Okay, this region has been divided into two triangles, two unequal triangles. On the other model, I'll show you how the division happens. We have to draw an imaginary line, okay, between the two ischial tuberosities. Okay, these are the sacrotuberous ligaments. So between the two ischial tuberosities, if we draw an imaginary line, the region, the triangular region in front of the line is the UG triangle or urogenital triangle. The triangular region behind my imaginary line, between the coccyx and the line, is the anal triangle. Okay? This will be holding the opening of the anal canal, and the urogenital triangle would be holding the openings of vagina and urethra in females and just urethra in males. All right, so before going or moving on to the structure of the perineal membrane, I have to talk about two spaces which are present in the perineal region in both sexes. Okay, and they are very important spaces functionally as well as clinically. Okay, so here in front of us is the illustration showing us the anterior smaller triangle, which is the UG triangle, because you can see there is an opening of urethra, the opening of vagina, and then at the back, the posteriorly, there is a larger triangle, which is known as the anal triangle or anorectal triangle. Okay, because we can see the tip of the coccyx. On either side are the ischial tuberosities, and these are our sacrotuberous ligaments. Okay, this is the imaginary plane, the transverse plane we have drawn between the two ischial tuberosities. And by the way, I want you to appreciate that there is a tendinous body, a fibrotendinous body present between the vagina and the anal canal. It's the perennial body. Okay, that is very important because we have to keep in mind that the position of the body is between the vagina and the anal canal. All right, so here you can see there are two structures on either side of the anal canal. They're known as, they're the spaces. They are actually wedge-shaped spaces. Okay, so the tapering portion of the or side of the wedge is, you have to imagine it's facing upward towards the body, and the base of the wedge is shown to you, which is at the lower level, like it's facing the perineal region. Okay, so these wedge-shaped spaces are known as ischiorectal fossae. Ischiorectal fossae because they are related to the ischial tuberosities. They're in the ischial region. But the thing is, it's a misnomer because we know that there is no part of rectum present in the perineal region. It's just the anal canal that enters the perineum, no rectum. Okay? But they have been keep on calling it the ischiorectal fossae. They are present on either side of the anal canal, and you have to imagine that the anal canal is going towards the board, okay? And why they are there, why these fossae are there. They are, you can see over here, they are filled up by the loose or the soft fat. Both the ischiorectal fossae are filled up by soft fat, which are providing a dead space for expansion of the anal canal at the time of defecation. Okay, every time when there is defecation happening, the anal canal is expanding lateralwards. Okay, so these ischiorectal fossae filled with the soft fat will be providing a dead space. And I have mentioned before, there is always a benefit or plus side of having dead spaces in our body. There is also like a negative point or a drawback of having dead spaces. So any sort of infection, anal canal infection or the rectal infection, can sit into these ischiorectal fossae. And by the way, they are very deep fossae heading towards the pelvic floor. Okay, they are filling out the region in the perineum. All right. And you can see in the midline, I have to draw one more thing. In the midline, they are separated by the right and left ischiorectal fossae, are separated by the perennial body, the anal opening or anus, and the anococcygeal raphe. This is another fibrous body, which is like it's been formed by the interdigitation of the iliococcygeus muscles and the pubococcygeus muscles coming from both directions and interdigitating in the center to create this anococcygeal raphe. And the perennial body is been formed. It's a fibromuscular body that has been formed by the interdigitation of the pubococcygeus element of the levator ani muscle, and that is, the sphincter vaginalis, or it's levator prostaticus in males. The fibers, they are coming from both sides and they are blending into this body. And this body is really very important. We'll be talking about its clinical significance in a few minutes. So here in front of us is the perineum. This green colored structure is the perineal membrane. It's representing the perineal membrane. Okay, just like the perineal region has been divided into a posterior larger rectal triangle or anal triangle, and an anterior smaller UG or urogenital triangle, the perineal membrane is also divided the same way. Okay, so here you can see that, okay, by the way, this region is the region or the spot point between the anal opening and the vaginal orifice. There is the perennial body. Okay, where all the muscle fibers, most of them, which are making the perineum and the pelvic floor, are coming and interdigitating with each other. Okay, so this perennial body is receiving mainly the fibers of pubovaginalis in females, or puboprostaticus or levator prostaticus in males, and the puborectalis, and also the transverse perineal muscles here, and the external anal sphincter, which is this one. All of them are coming and blending in together at the region of perennial body. So we can imagine it as a thumbpin. So it's holding all the structures together in the floor of the pelvis and perineum. Okay, so it is indispensable. It's an indispensable support to the pelvic viscera. So what can happen in case of damage to this perennial body? That usually happens when the obstetrician, as a result of a difficult vaginal delivery, she tries to give an episiotomy, an incision, which has been usually given in the posterior wall of the vagina. As you can see, this is the posterior aspect. So usually if the cut has been given like this, close to the midline, it can damage the perennial body. Okay, so that normally they ask to give the incision like this, in this fashion, away, as much away as possible from the perennial body, so that there are less chances of damage to this body. And you are able to observe how many muscles are coming and blending into this point. So if something happens to this perennial body, it gets damaged during episiotomy, the female definitely will be suffering from either fecal incontinence, or sometimes even the vaginal prolapse or uterine prolapse. That can also happen because this whole region will be loosened up. Okay, that is the clinical significance of perennial body. So here is again in front of us the same model with all the muscles. So this is the levator ani, or the pelvic diaphragm. There is a space, there are two spaces, they're known as the perennial spaces or perennial pouches. Okay, so there is a deep perennial pouch, which is a space between, by the way, this green thing, this green structure is the perineal membrane. Okay, so the space between the levator ani muscle or the pelvic diaphragm and the perineal membrane is the deep perineal pouch. One of the major contents of this deep perineal pouch would be the transverse perineal muscles, the external anal sphincter in both sexes, and the transverse perineal muscles in both sexes. So, and there are many other structures and nerves and vessels. And here you can see that our pudendal nerve is passing. There is the vascular bundle is not visible in this model, but we have to imagine that the pudendal neurovascular bundle, it's passing out, or it's passing through the greater sciatic foramen, entering the lesser sciatic foramen, and it's distributing its branches to the perineal region. Okay, this is how it has escaped the pelvic cavity, and it did not pierce through the pelvic diaphragm. Okay, so the contents of the deep perineal pouch are the muscles, particularly the external anal sphincter and the transverse perineal muscles. The space or the pouch is the space between the levator ani or the pelvic diaphragm and the perineal membrane. That is the deep perineal pouch. The superficial perineal pouch would be, imagine my hand is the superficial fascia of the skin. So the superficial perineal pouch would be the space, a potential space between the perineal membrane above and the superficial fascia, which is also known as Colles fascia of the skin. Okay, so I have a small makeshift model for you to explain the things and their placements a little bit better. Okay, let me orient you. We are looking at the pelvic floor from the top, and here are our three structures. So this is the posterior, this is the anterior, and you can easily figure it out that the green colored clip is the rectum, the red one is the vagina, and the blue colored clip is the urethra. Okay, and just remember that within the pelvic cavity we have the rectum, the vagina, and the lower part of the bladder, which is the neck of the bladder that converts into urethra. When they pass through these openings or orifices and they enter the perineum, they are no more known as rectum or the neck of the bladder. The rectum is being now known as the anal canal, the vagina, the lower end of vagina, and the urethra. In females, it's the tip of the urethra. In males, it would be a different story. We'll be talking about it when we'll do the male and female reproductive system. Okay? So now look at this, that this sandwich-like structure or model is representing our perineum. So this is the levator ani or the pelvic diaphragm. you're looking at, or you're looking through the deep perineal pouch. So you can see this is the perineal membrane, the pelvic diaphragm, and in between are sandwiched the transverse perineal muscles, and also there would be, external anal sphincter and the urethral sphincter. Okay, here you can see, if I lift up the perineal membrane, my thumb is in the superficial perineal pouch, because this off-white structure or membrane is the Colles fascia, or the superficial fascia of skin. So my thumb is in the superficial perineal pouch, and my index finger is in the deep perineal pouch. Okay, so the contents of the superficial perineal pouch, they are mainly more prominent in the male because there is scrotum and there are other structures, but in females it's just the glands, and we'll be talking about them later on.